Hello, I am Dr. Najil Hamid, a nephrologist from Kidney Surgical Hospital in Damascus, Syria. In this lecture series, we will discuss acute kidney injury in patients who have acute coronary syndrome and undergo PCI. First lecture, we will have some overview of definition, classifications, and causes of acute kidney injury in these patients. Contrast-induced nephropathy is the usual known cause of acute kidney injury in these patients. But let's review its definition. An acute kidney injury occurs within 48 hours of contrast media injection, not attributed to other causes. So we have to rule out other causes before saying that it's CIN. This is very important point for two reasons. First, CIN has no specific therapy when it occurs. All we do is fluid overload management in addition to electrolytes disturbances such as hyperkalemia and managing metabolic acidosis. Which means conservative therapy and possible need for hemodialysis. Second, each one of the other causes that may lead to acute kidney injury other than CIN has a specific management, differs from the others, and usually when we miss the diagnosis, it carries a very bad outcome. So we should be very careful and we need to be aware of the other causes. Classifications. First, pathology that causes cardiac and renal injury. Here we have to find a clue for a pathology that may harm both the heart and the kidney. We need to look for a clue carefully for this type of injury. We will discuss these clues extensively in the next lectures, including signs, symptoms, labs, etc. Second, cardiac injury causes renal injury. Here we have to be sure about the type of coronary injury that happened and its consequences, cardiorenal syndrome type 1, and if we have right heart failure, etc. Each type of pathology has a specific consequences on the kidney, and specific management will be needed. Drug-induced acute kidney injury is a very important classification. We need to look for drugs that may harm the kidney before, during, or after the procedure. Always we should consider drugs. Another classification is hospital and community acquired acute kidney injury, which depends on time, manner. Very important classification. All these 4 points and classes will be discussed in the next lecture, how to use them, how to ask about them, and how to depend on them to build up a good differential diagnosis that will help us to know the actual cause of acute kidney injury. Possible causes. Now try to classify these causes into the appropriate group or classes that previously mentioned. Cardiogenic shock, which as you know has a poor prognosis. Aggressive blood pressure reduction. Here when we have a newly perfused cardiac tissue and we still in standing heart state, adding antihypertensive therapy will reduce blood pressure more and will lead to pre-renal azotemia, atherosclerotic disease of the kidney, which may happen after maneuvers on atherosclerotic aorta with the guide, infections such as COVID-19, rhabdomyolysis secondary to statins or viral infections, NSAIDs that may be prescribed inappropriately for anginal pain, hypovolemic shock, which could happen secondary to GI bleeding related to stress and anticoagulants prescribed, or big hematoma in the puncture site or retroperitoneal hemorrhage. Hypovolemic shock also may happen secondary to inappropriate overdiuresis using Lasix after contrast media injection and suspected fluid overload. Acute interstitial nephritis for some drugs. Thrombotic microangiopathy and other vasculitides. TMA may happen as primary event that may lead to both coronary and renal injury, or secondary when we use clopidogrel. Aortic dissection, which may descend to renal vessels. Anticoagulant related nephropathy, which is described secondary to warfarin, then to the other anticoagulants. Very important cause should be considered and carefully evaluated. These causes and in addition to classifications will be combined in the next lectures and discussed in appropriate case reviews. All you need to know in this lecture is CIN is not the only cause of acute kidney injury. Even CIN in some studies is discussed about if it exists. Other causes are very important and should not be missed. Each one of them has a specific management, which in some cases cannot be delayed. No extensive labs or procedures are usually needed to reach these causes. Just a good history, physical exam, and detailed vitals before, during, and after PCI are usually enough to build up a good differential diagnosis. Time manner is very important, and we need to know when acute kidney injury occurs. This is very important point. We need to focus on it as the classification of hospital or community acquired acute kidney injury. We need to know the time of acute kidney injury. Next lecture we will talk about workup and how to build a good differential diagnosis. We will depend on cases, and we will review causes and classifications and how to think about these cases and how to manage them appropriately. Thank you very much and goodbye.